Hello, everyone. In this video, we're going to start the discussion of the integumentary system disorders. And this includes skin, hair, and nail disorders. And let me start first with the anatomy of the skin. So the skin is made of the dermis. So everything in the skin is present in this layer, the dermis. So we have blood vessels, we have nerve endings, we have the hair follicles, we have the sebaceous gland associated with the hair follicle, we have the sweat glands, we have everything in the dermis. The dermis is covered by a scaly layer known as the epidermis. So the skin is the dermis and the epidermis. The subcutaneous tissue, which is considered by many authors separate from the skin, is a layer of fat, and it serves as heat insulator. If you have a lesion very superficial in the dermis, like folliculitis, for example, or pustule, that is very superficial here in the epidermis and the very superficial layer of the dermis, then it is enough to treat it with topical antibiotic. But if the infection goes deeper, then topical antibiotic will not be enough, and we will need systemic antibiotics. For the anatomy of the nail, so I just want you to focus on three structures: the nail bed, which is part of the finger, and on top of it grows the nail plate. Notice that it is the nail plate that grows in length, not the nail bed. And some nail lesions are like lines. So if you have the line or ridge in the nail plate, so as the nail plate grows, this lesion moves distally. But if you have a lesion in the nail bed, it does not move because the nail bed does not grow. It is the nail plate that grows. The tissue on both sides of the nail is known as the paronychium, and inflammation of the paronychium is called paronychia. The anatomy of hair. The hair follicle is present in the dermis, and attached to it, the sebaceous gland. And this sebaceous gland, its activity and secretions is stimulated by androgens. And males and females have androgens. What's the source of androgens in the female body? It is the adrenal cortex, the innermost layer of the adrenal cortex, zona reticularis. And the too much activity of these sebaceous glands together with a bacteria known as propionibacterium, both together contribute to the pathophysiology of acne. Now let's talk about skin lesions. We can divide skin lesions into primary skin lesions, secondary skin lesions, and vascular skin lesions. So let me start with the vascular skin lesions. Vascular means it involves blood and blood vessels. For petechiae, purpura, ecchymosis, these three lesions, the blood is outside the blood vessels. So these are some sort of bleeding. And the difference between them is the size. So petechiae, the smallest, ecchymosis, the largest. In telangiectasia and cherry hemangioma, the blood does not get out of the blood vessel. So it's a disorder of the blood vessels with the blood inside. Whereas petechiae, purpura, ecchymosis, in these three lesions, blood leaks outside the blood vessels. Now, what is a primary and what is a secondary skin lesion? When the skin lesion develops on top of a normal skin, we call it primary. And then Some changes can happen to this primary lesion, whether because this is the natural progression of the disease or because of you scratch it, it's itchy and you scratch it, so you get some secondary changes. So secondary lesions develop on top of primary lesions, whereas primary lesions develop on top of a healthy, normal skin. We have different primary lesions. Both macule and patch, both are flat lesions. They are not raised on the surface of the skin. The macule is smaller than 1 centimeter. The patch is larger than 1 centimeter. Papule, plaque, and nodule. These three lesions are raised. They are not flat, they are raised. We call it a papule when it is smaller than 1 centimeter. We call it a plaque when it is larger than 1 centimeter. And the nodule, this letter D, let it remind you that it is deep. It is large and deep. So the nodule is large and deep. Vesicle, bulla, and pustule. All these three lesions have fluid inside. We call it a vesicle when it is smaller than 1 centimeter. We call it a bulla when it is larger than 1 centimeter. And we call it pustule when the fluid inside is pus. And usually the pustule is related to a hair follicle. And infection of a hair follicle is called folliculitis. Other examples of primary skin lesions, the wheal, which is the lesion characteristic of the urticaria or hives, and other primary lesions like tumors, like lipoma, for example, or cysts, like epidermoid cysts. If we get to the secondary lesions, scale or crust. Scales can cover a primary lesion, like the patch or the plaque. So, for example, a skin disease called psoriasis, it starts as a plaque, which is a large raised lesion, and then this plaque becomes covered with silvery scales. So here, the silvery scales are the secondary lesion, and the plaque is the primary lesion. Crust is dried serum, infected serum. So one skin condition, impetigo, it starts as vesicles, or actually pustules, or vesicles and pustules. And when these vesicles get deroofed, when they get deroofed, when they rupture, and the serum comes out and then dries, it becomes a crust. Lichenification is the opposite of atrophy. Lichenification is thickening of the skin due to scratching. Atrophy is thinning of the skin. Scar and keloid both develop on top of a wound. So the scar is the normal or usual way by which wounds heal, by fibrous tissue. The keloid is an ugly scar that extends beyond the margins of the wound. Excoriation and fissure. In these two conditions, there is loss of a skin line. There is linear loss of the skin. When it is superficial, we call it excoriation. Excoriation like scratch marks. When it is deep and slit-like, we call it a fissure. In erosion and ulcer, there is area loss of skin. So excoriation and fissure, both are linear loss of skin. Whereas erosion and ulcer, it's not linear loss, it is area loss. And we call it erosion when it is superficial, and we call it an ulcer when it is deep. So we already talked about the differences between primary and secondary skin lesions. Okay, some characteristics of different skin lesions. The most common pruritic or itchy skin lesions, some examples: atopic dermatitis or eczema, urticaria, scabies, scaly skin lesions, psoriasis, actinic keratosis, which develops in sun-exposed areas and is precancerous. Once we have vesicles, the first differential diagnosis that should pop up into your mind is herpes. And if it is not herpes, then the second most common is contact dermatitis. Hypopigmented skin lesions, example, vitiligo. Hyperpigmented skin lesions, example, acanthosis nigricans. Malignant skin lesions, we have 3 examples of malignant skin lesions. And these are, the most common is basal cell carcinoma. The second most common is squamous cell carcinoma. The least common, but the most malignant, is melanoma. You don't need to say malignant melanoma because there is no benign melanoma. I just put malignant here just to remind you that this is the most malignant of all skin tumors. Moving on to nail lesions. And I'm going to talk about just one example of nail lesion, which is the fungal nail infection or onychomycosis. Onycho refers to the nail, mycosis refers to the fungus. So onychomycosis refers to nail infections caused by any fungus. The characteristic nail changes include thickening of the nail, as you see in these pictures, with yellowish or white discoloration distally due to hyperkeratotic debris accumulation. Pitting edema does not occur in onychomycosis. One of or several of toenails or fingernails may be involved. It is rare for all nails to be involved, so some nails are spared. Most patients are concerned for cosmetic reasons, but some might have associated pain. And actually, when you have fungal infection of the nails, you cannot treat it topically. It has to be treated with systemic antifungal medications. Hair lesions. And here I'm going to talk about just one example, which is hirsutism. And hirsutism occurs only in women. So when women put on their hair suits, that's hirsutism. So what happens here is the development of an androgen-dependent masculine pattern of hair distribution, especially in the face. So you can notice here, this lady is growing a beard here and a mustache maybe. And the most common cause of hirsutism is idiopathic. And the second most common cause is polycystic ovary syndrome. So these 2 causes are the most common causes of hirsutism. Less common causes of hirsutism are hyperprolactinemia and Cushing syndrome. Okay, I'm going to end this segment here, and we'll talk about more skin conditions in the next segment.